Now, my first talk here was all about fear, and this slide is one of those fears I didn't talk about, but it was actually my dinner last night. I thought I do quite a bit of travel, and I've always wanted to try insects, and then these were not actually frying away, just sitting there in the heat for some time, and I thought I'd be brave and work out how good my immune system is. So I'm here, I haven't died, and I can actually recommend them. They're quite tasty. Who's had insects? They are great. I think they're the future as well. Anyway, that's bravery.
That's what we had yesterday.
Well, tomorrow I fly, and that'll be fun and entertaining for the flight crew. Today I'm going to talk a little bit about how to recognise when your patient is getting sicker, and I'm also going to talk about a little bit about the way ED physicians think, ED doctors think, and maybe ED staff think, because we think a little bit differently as well. So we'll go through a case and talk about how to recognise that sick patient. And part of that, going back to my original talk, is through experience. So for those of you who worked for a while, you'll develop an inner voice, which I tend to rely on now, to not necessarily know that you know something is going on, but something is going on and you're missing it. And the more medicine I do, the more I come to rely on that voice to tell me that there is something going on with my patient. So we'll work out some ways of working that out together. So we're going to talk about the warning signs of how you know your patient's sick. Now, sometimes medicine's obvious. So if the person's got an open wound into their chest and you can see their heart beating, you know they're doing very poorly and you need a bit of help. But sometimes they're much more subtle. And as I said before, as people get more complicated and they come in with every sort of organ failure you can think of, you've just got to be aware of which patients will bite you in the ass, which ones are going to sneak under your radar, which are the high-risk patients. So you need to have a bit more thought about those. Where to get information, and I'm going to talk to this as an ED doctor. This is a talk I originally do to my junior doctors, so there will be hospital-based, but I think it is applicable to other parts of healthcare as well. So how do you know your patient is sick and where to get information from about that? And then how to respond to the deteriorating patient, we'll talk about that too. So firstly, a case. 80-year-old lady, boarded by ambulance, being found on the floor. Now it seems to me that the role of 80-year-old ladies is to fall onto the floor and be found by their daughters. It's never by the sons, so women are keeping the population alive. She's had trouble breathing, this is what the ambulance have told us, trouble breathing, very difficult getting blood pressure en route, can't get a line in, which sucks. She's quite drowsy and her blood sugar is just reading high. So for those of you who work in the pre-hospital environment or those who work in the hospital environment, not an unusual presentation. And this is where your brains are starting to think about, okay, what's going to come in through the front door, mentally planning ahead. And again, when you're talking about reducing fear, starting to prepare your team and yourself for whatever's going to come in through the front door. So what are the warning signs? So obviously triage, and if you've got an ambulance, paramedics have told you that something bad's coming in. In my world, nursing concern is the most important. So I am very lucky that I work with a huge group of nurses, all of whom save my life on a daily basis. And they're the eyes and the ears of the hospital. They spend much more time with patients than I get to, and they know through their experience when something is going on. And to my detriment, the times when I've made a mistake is where I haven't listened to those voices. Family concern, particularly when looking after children, is increasingly relevant. And it's hard to get that balance right because people are always concerned about family when they come to hospital. We do need to sort of think about, is this an appropriate level of concern for the family, or is this actually really unusual? Are we missing something because the family knows the patient better than we do? Junior doctors are concerned if they come to me and say, Dave, there's something wrong here, go and see the patient. And then changes in vital signs. So one of the things I like to teach, especially in the hospital environment, I'm trying to get my junior doctors to stop writing vital signs within normal limits in their notes. That doesn't mean anything to me, and it doesn't mean anything to the future doctors and nurses looking after the patient. I think every time you check a patient, you should write down their vital signs. And that way, at least, you've got some idea of which direction they're going. Are they stable? Are they changing? And you can pick things up quite early. And we'll talk about the vital signs that are useful a little bit later on. So I think healthcare, and certainly medicine, is a bit magic. My dad, there's no one medical in my family, there's no one even remotely scientific. They think we're druids. My dad thinks we're sort of some sort of magical beast. But I think there is a bit of magic to medicine and to nursing and paramedicine as well. I think once you get experience, your end of the bed test is one of the most useful tools that we use to pick up sick patients. And that's where you can walk into a room and you immediately know, yes, this is bad, or no, this is okay, you've got time to go and do something else. And I think that is something that you have to learn through experience. It's very hard when you first start your career to walk in to know whether you're missing something or you're not missing something. Because ED physicians are simple human beings, we do our ABCDE approach, and I'll tell you why that is later on, and then review of the observation chart and take new ones. So the other thing I'm trying to teach my junior doctors is they can actually take a pulse and a blood pressure and a blood sugar. I can see I hit a nerve there. But it's amazing how often their arms fall off when you ask them to do something like that. But also just have a look and see what is the pattern of this patient, where are they going, what's been happening to them, where are you in their illness journey. So, standard approach, ABCDE, look for and treat immediate life threats. And the reason we do this simple approach is that it's cause agnostic. So it doesn't matter what's wrong with your patient. Frequently in my role, I don't know the patient's name, I don't know anything about them, I don't know their past medical history, I don't know what medications they're on, I don't know what's wrong with them, I have none of their results back and I still have to treat them. Okay, that's ED, that's very different. And so that means if I can go into my ED at 2 o'clock in the morning, I've just driven there very, very fast, I've got a couple of speeding tickets en route, I'm still in my pajamas, I can still resuscitate my patient, I can go A is okay, B is a problem, C is a problem, D is a problem. And I can work through that without knowing anything else about my patient until I get an idea of what's going on, or my brain wakes up, or someone tells me. So it's quite a useful tool, and that's why we use it for all our sick patients. That approach also gives your team something to do while you sort out what's going on in your own head. So it's quite a useful distraction tool. If you walk into a room and you're responsible for a patient who's looking very sick and you have no idea what to do, you can actually go back and say, okay, can you please look after the airway, and can you listen to the lungs, and can someone do the blood pressure please? And set a series of tasks until your team catches up and you actually work out what's wrong with the patient. So it gives you some structure, which I think is quite useful. So how do we think? How do I think? Not very well unless I've got coffee, but we're both the same and different to other medical specialties. And that's part of the way that some doctors find ED very challenging, and sometimes ED doctors realise that's where I need to be. So we often treat patients, as I said, with less information. So less information, less time, more interruptions, huge numbers of interruptions, and more change in the status of the patient over a quicker period of time. So from an outsider's point of view, an emergency department is a very chaotic place. But for those of us who work there all the time, they realise there's a lot of structure there because our patients aren't standardised and they aren't sorted out, and we don't have access to the information, and we're also often very time poor as well. Our patients are high risk. They're high risk because they come to us when they're their sickest, and they come to us because they haven't had any treatment or investigations or diagnosis or any management at all. And it's often initially problem focused. So if someone comes in and they have no airway, you fix the airway before you do anything else. If they need blood pressure management, you manage their blood pressure. If you need to stop bleeding, you stop the bleeding. So sometimes you're actually treating patients before you do everything else that we're traditionally taught we have to do. And the weirdest thing about my job, and I'd like to claim that it is an ED specific thing, is extremely high decision density. So we make a decision, as an senior ED doctor in a very busy department, I will make a decision about a patient or something probably every minute. Can this patient go home? Is this ECG normal? What's the dose of this? Does this person need sedation? Can this person be admitted? Is this a fracture? Is this person septic? Can you look at this for me? Every minute for 10 hours straight. So it's a very weird place to work. So sometimes I think the ED doctors think a little bit differently. It's a circular sort of thing. It's, what's the problem? What do I need to do? Did it work? Is there a new problem? Or have I solved it? Did it work? And round and round and round until I have a diagnosis, or the patient's stable, or I've moved the patient on to someone else's care. That's not how we're taught. We're taught there's a problem, then take a history, do an examination, do some tests, make a diagnosis, do some treatment, and then say, did it work? So that's the way medicine is taught. Certainly ward-based medicine is usually that. And it doesn't always work in the acute setting in an emergency department, and probably even pre-hospital as well. So we think slightly differently as well. So there are some high-risk patients that I think you need to keep an eye on, and certainly ones we miss. And both extremes of age. So we've had fantastic talks about neonates and talking about fear initially. So little babies are cute and dangerous. And then old people are cute and dangerous as well, but at a different age, a very frail, much higher risk of things going wrong. There is a tendency in medicine, certainly, to blame the patient when we don't get the information that we need. And I'm guilty of that myself. And there's a lot of frustration sometimes where someone doesn't tell me what I want them to tell me, or they don't tell me in a way that I want to receive that information. So again, medicine is quite formalised, and I'm sure nursing and paramedicine as well. There is a language that we learn of how to take a story from someone we've never met and take that story in a certain format so that we can do a procedure to it, which is diagnosis. And then when we refer a patient, we refer in a specialist way as well. So we transfer information between the patient, the clinician, to other clinicians in a standardised way. And when patients don't do that, we get really frustrated or we miss stuff. So the poor historian in my practice, it's the farmer. So who's a farmer here? There you go. So terrible. Terrible historians. What's wrong with you? Well, that's your job. Okay, fine. How did you get to hospital? I drove. Okay. What's your health like? Oh, it's not bad. Any medical problems? Yep. You know. So that could go on for quite some time. And I think it's just because people live their lives slightly differently, but it does cause frustration, particularly if you're under stress, that you're not getting information the way you want to get. I think we do a disservice, certainly in Australia, that we treat people from other cultures poorly, and in particular, people who either non-English speaking or have English as a second language. I think the reason we do that is because of expediency. We're under pressure, things take time, it's much harder to find someone who can translate formally and get a formal translator. But I think we miss a lot by not allowing people to speak in their language of comfort. Patients at night time. Our health system says things don't happen at night time. We can shut most of the hospital down, we don't have to do any tests, everyone can go home except for me. We won't have this, we won't have that. We'll turn off most of the lights, get those spooky corridors from my first thing. So hospitals only work during daylight hours and occasionally sort of like to 8 p.m. And then in my very large ED, which is a bit like a rabbit warren, there are cubicles of death, we call them. And these are poorly designed places that the architects have put in there for some reason where you can't see the patient, you never walk past them, the door's shut. We've got a couple of cubicles in my hospital where there's a giant pillar supporting the hospital right in the middle of the patient bay, and you can't see the patient or the monitor. And then there are people at high risk because they're not in the area that you expect them to be sick. So if you've got a patient who's in a resuscitation area, you'll come to it with your own expectations. They're sick, they're in resus. So you won't pick up the little old lady who's got a ruptured AAA sitting in the corner somewhere else or in a bed that's not in a high acuity area. And then people you don't like, which is not uncommon. Look, if someone's rude to you, if they're racist, if they're violent, if they're manipulative, if they're scary, you don't like them. That's normal. That's a normal thing. And as health practitioners, we have to put aside that and say, I know I hate you. You deserve all my hate. But I also have to try and make sure you don't die. And people that you don't like don't get good care. I think that's really, really important, because certainly in the high-risk environments we work, we do encounter people that we naturally just don't like. So, pattern recognition. A lot of the way we solve problems is by doing a quick sieve, saying, okay, do I need to do it? So airways, is it threatened? Yes or no? If it's really bad, do I need to prepare for intubation? And if it is threatened, what can I do? So you can clear it, you can bag if need be. If it's preparing for intubation, you're doing pre-oxygenation and you're doing an intubation plan. We don't know necessarily why the airway is obstructed or threatened necessarily, but immediately when we're doing an ABCD approach, you're starting to think like this. What do I need to do now? How do I stabilise this patient until I get more information? From a breathing point of view, is it normal? Yes or no? If it's laboured, get some oxygen. Do they have any reason that you can detect clinically that they might have laboured breathing? Do they need ventilation? And again, do we need to prepare for intubation? C, can you get access? Are they shocked? And then you think about the types of shock, get a quick ECG, and then think about ways of actually managing that shock until you get the patient back to basis again. Again, usually as you go through this sieve, information comes back and saying, actually, the reason this person's shocked is because they've got septic shock, or they have an arrhythmia and it's cardiogenic shock, or they've got signs of a PE, or whatever else it is. And then D, are they awake? Are they normal? Are there other things like blood sugar as a sign of a toxidrome? And then are there reversible causes? Is there something I can't see that I need to do a CT scan for? Am I heading towards intubation? So this is just generalised sieve for anyone who's sick. We still don't have any information about our patient. This is cause agnostic, but it's a little way of how we think when you've got someone who's unwell in front of you. And this can be done very quickly, which is why we do it. As you get more information, you can go into more detail, you can do more specific examination, and you can refine your diagnosis and then refine your plan as well. So in assessment, really, for your sick patient is, what do I need to do right now? Is this patient okay for me to go and get some help? Do I need to get some help in here? Do I need to open up the airway? Do I need to do CPR? What do I need to do right now? And then also, what's coming up? So this is what I think this direction this patient's going. This is what I think my presumptive diagnosis is. This patient is heading towards either this procedure or this test or this endpoint. What's my next thing? And the reason I am going through this is I think that one of the roles that I think we often have when we have sick patients is as a team leader of a group of people who are resuscitating a sick patient or assessing a sick patient. And taking that leadership role is often quite scary. And one of the reasons that people find taking a leadership role in resuscitation or dealing with sick people scary is an assumption that if you're leading a resuscitation, you have to know all of medicine. Okay? So people often don't put their hands up and say, look, I'll team lead here, because there is a worry that people are going to assume that you know all of medicine and you have all the answers. In reality, if you've got someone who's sick, you do need to have a team leader. You need someone who's going to guide the resuscitation, guide the assessment, but it doesn't have to be everything. It just needs to be going through A, B, C, Ds, A, B, C, D, A, B, C, D, E, if you want, until you get a diagnosis or you get some information. So, the problem list is another way of approaching a sick patient. And it's my way of dealing with complex and sick patients. In those of you who see patients who are sick, who writes problem lists? 2, right? Okay, so you'll learn something. So a problem list is my way, in my notes, of writing down what I think is wrong with this patient. And it might be immediate resuscitation goals or problems. It might be a series of medical or surgical issues. And it gives me some idea of whether there's one thing going on or there are multiple things going on with this patient. So it helps me think as well. It's a way of organising thoughts in patients who are very complicated or unstable. And I think, yeah, so we'll just do a problem list. So it might be, so airway, they might need respiratory, they've got respiratory failure, they might have pneumonia, they've got possibly septic shock, low CGS, high BSL. And this goes back to our little old lady who's had a fall, might have HHS, possible right fracture, NOF, rhabdomyolysis, renal failure, hyperkalemia after being on the ground. So again, in patients who come in who are unsorted or who seem to have every single problem in the world, as you assess them, as you recognise that they're sick, that might come into a series of problems that you can then address as a plan. So if I can go backwards here, which is going to be the tricky bit, because this is not going to work. And so reducing cognitive load, I think I discussed in my first talk, as one of those things about getting other people to do your work for you. And certainly in paediatrics, it's getting someone else to do the calculations. It might be dividing up the various things that this lady needs and giving people tasks. So can you manage the airway? Do you mind arranging the radiology? Can you get access in this patient? Can you work out what antibiotic to give? There might be various things you can divide so you don't have to think of them yourself. Use your team. Again, if you're lucky enough to work in a bigger place where there are a lot of people, then you have the opportunity to have many brains in the room, many pairs of hands. I do know that quite a few of you work in rural and remote areas where you are by yourself, and that's really, really hard. Everything's easy for a doctor who's in a big hospital surrounded by all the things in the world, and it's much harder if you're at a roadside accident or you're in a small nursing post with no one to help. Ask for help early, and as I said before, you guys are living in the future where all the help you need is in your pocket. You can call for help, you can look up guidelines, and people will help you if you ask. And then do simple things. The vast majority of sick people don't need complex neurosurgery straight away, but they might need oxygen, they might need some fluids, they might need some pain relief, they might need some antibiotics, they might need simple things. And often, especially when it's complex, if you do the simple things well, your patient will survive to get the complex things later on. If you forget to do the simple things well, then it doesn't matter how fancy you are, your patient probably won't do well. And then, as I said before, for all these sick people, particularly when you're trying to assess whether someone's sick or not, go back to simulations. So in your head first, remember your scary patient that you all dreamt about and has probably had nightmares since and you'll see next week. So think about them. Practice in your head what you're going to do when they turn up at your hospital. And then if you go back to work after this holiday, do simulations. Plan for the bad stuff to come in. How are you going to work as a team? How do you assess your patient? How do you resuscitate? How do you do the hard things that you don't know how to do? So the other difficulty when you've got complexity is the fact you've got, in many cases, multiple different patients at the same time, all of whom are demanding your attention. Now this might be in a smaller centre, just 2 patients, that might be enough. And in a big hospital, it might be just a normal day where you're getting 280 patients a day and they're all sick. So some part of what you're doing when you're assessing people, are they sick or not, is working out, can things wait? So what do I have to do for this patient? Do they need pain relief, an X-ray, a fluid? Or what would I like to do? So that's spending time with them, doing formal assessments and so on. Sometimes you have to divide your time up because you don't have time to do everything that you want to do for every patient. And what can I ignore? What is not my problem? And that's really important because people will come in expecting you to save their entire life and change everything. There are things that you can't fix. So knowing that someone else's job later on can fix that problem. Again, remember this from my junior doctors, listen to nurses. Thank you, nurses. You've saved my life on many occasions and the vast majority of my patients as well. But more importantly, listen to the little voice in your head. For those of you who've been practicing for a long time, you'll have that voice. If something feels wrong to you, it probably is. If you think you're missing something, you probably are. If you think the person might need intubation, they probably do. If you think they're septic, they probably are. So once you get experience, your little voice in your head does that end of the bed test for you and will usually tell you the right thing. So don't ignore that voice. Examine your patients. Just do that. Even if you have no idea what you're doing, just examine them. Look everywhere, poke everywhere, prod everywhere. You'll miss much less. That's it. Finally, I actually have a video, if you'll play. Hopefully it'll play.
So you know elephant that they can hold the breath underwater 18 seconds. And they can floating for 6 hours non-stop.
Oh, sorry. I didn't know they did underwater as well. I got drenched by this elephant. We have history. There you go. It's having a great time.
Elephant can swim around 1.5 kilometers per hour.
And he doesn't want to get out. Okay. Thanks, Jared. Thanks, everybody.
Thank you very much, David. And let's hear it one more time for all our presenters for this week.